we are going to discuss a very important topic, and that is otitis media. See, many times parents come to us, maybe, as we are closing down our OPD, and they say, sir, this child is having fever and he's crying a lot for the last 2 to 3 days. Then I ask him as to what is the way in which the child is crying. So they say, sir, he goes to sleep, again he wakes up, again he goes to sleep, again wakes up. And then some of them say that the child pulls at the ear and so on and so forth. And then I ask as to whether he had any respiratory infection, cough and cold in the last 2-3 days. So the parents say, yes, sir, he has been having cold for the last 3-4 days. And then at the back of my mind, I always start thinking whether it is, plain simple rhinitis or whether it is associated otitis media. And the causes for which, children are brought to the OPD, which involve the ear, basically they are related to otitis media, otitis externa, and our teacher used to tell us that when you pull the external ear and if the child shouts, that is otitis externa. Okay. And I would always remember that. Also, another cause is the impacted wax, which is also related to the ear. Now, the point is that the child is irritable and febrile. So whenever a child is irritable and febrile, one should always suspect otitis media. And the relevance of this particular topic in the developed countries is that, there is concern about the complications in the form of conductive hearing loss or language delays or maybe cognition, that is understanding a subject. While in the developing countries like ours, this infection may spread to the mastoids and may have intracranial complications. Of course, all the audience knows that we have vaccines like pneumococcal vaccine, which have really started rather spreading because of the government's initiatives. And then the impact of this particular vaccination, that is pneumococcal conjugate vaccine, on the incidence of acute otitis media and the concern about the use of antibiotics. In the Western countries, just as a pediatrician suspects that there is otitis media, he will just look at the eardrum and he will prescribe the antibiotic. So some of my friends say that the pediatricians there just want a pretext to start antibiotic. So it is one of the conditions where antibiotics are used, maybe misused, maybe overused, or maybe they are right. And all these things are going to be discussed by Dr. Abhay Shah today in his talk. Remember, we in the first part of this series, we discussed about the microbiology of the respiratory infections, and we saw that rhinitis usually is viral, sinusitis is bacterial, and then eustachian tube, which connects the throat with the ear, and the organisms which are in the throat, they will travel to the middle ear. And in 70% of the cases, we know that otitis media is bacterial in origin. And the organisms which produce the problem are called as autopathogens, OTO. That means the pathogens which are in the middle ear. So there is a lot of interesting information about this particular disease. And this is basically a disease of early childhood. And that's why an important, topic which a pediatrician must know, and even a general pediatrician and a general physician should know about it. So with this short introduction, I will request Abhay Bhai to, share his presentation and discuss about this topic for initial 35 to 40 minutes. Then we will summarize, and then we will have audience questions. So it's over to you, Abhay Bhai.
Yeah. So thank you, Dr. Pramod sir, for this wonderful introduction of the topic, and thank you, Dr. Surekha, for introduction of myself personally. So as Dr. Pramod sir has told, that this is one of the most important topic as far as otitis media is concerned. So let us first find out what is the magnitude of a problem. So it is the most common reason that the parents bring their children to our pediatric office. So otitis media is underdiagnosed and underestimated problem, because in India, still we are not using the otoscope that regularly. And as per the literature, nearly 75% of the children experience at least one episode of the otitis media by the age of 3 years. So before the child reaches to third birthday, nearly 75% of the children, that is 3/4 of the children population, will have at least one attack of otitis media. So the number is really, really huge. Nearly about half of these children will have a 3 or more year infection during the first 3 years. Means the recurrence of the disease, that is recurrent otitis media, is also quite common. And if you look at the medical cost and cost lost wages because of otitis media amount to $5 billion in a year in the United States. Means because the child is sick, parents cannot go to their workplace, and therefore there is a huge financial burden associated with otitis media. And lastly, the tympanostomy tube placement is the second most surgical procedure carried out in children in United States. So it's a huge problem, often underestimated and underdiagnosed, because in India we do not routinely use otoscope for the diagnosis of the otitis media. Yeah. Now, let us try to find out what is otitis media. So the definition of otitis media has three important components. Number one, there should be a recent abrupt onset. When I say it's a recent, the onset should be less than 48 hours. Second, it has the signs and symptoms of medial ear inflammation, as well as the signs and symptoms of the middle ear effusion. So abrupt or recent onset of less than 48 hours, plus signs and symptoms of middle ear inflammation, plus signs and symptoms of middle ear effusion is equal to acute otitis media. So for the definition, for the diagnosis of acute otitis media, all three components must be present. The signs and symptoms of middle ear inflammation will be fever, there may be otalgia, and there may be a distinct otorrhea. But remember, friend, though we say it is fever, fever is often present in 10 to 12% of the cases, number one. Second, low-grade fever is also seen in 30 to 40% of the cases. So fever is not the major component. It is one of the components, but it is not always a major component as far as otitis media is concerned. So there is distinct erythema of the tympanic membrane, or there is distinct otalgia that results in the interference with the normal activity of the sleep of the child. So that the child cannot sleep, child has excessive crying because of otalgia, child is irritable, and this may be associated or may not be associated with the fever. As far as the middle ear effusion is concerned, it is indicated by presence of bulging of the tympanic membrane. Not only bulging, there is a limited mobility, or the mobility of the tympanic membrane is completely lost. So when the mobility of the tympanic membrane is lost, it is again a sign of middle ear effusion consistent with the diagnosis of otitis media. In some cases, you may find air fluid level behind the tympanic membrane, and in some cases there may be a purulent discharge or a seropurulent discharge or mucopurulent discharge coming out from the ear. So that is what is described as a otorrhea. Out of this, bulging tympanic membrane, opaque and immobile tympanic membrane has a nearly more than 90% predictive value. As against this, the erythematous tympanic membrane without bulging has only 7% of the positive predictive value for the diagnosis of acute otitis media. Means erythema of the tympanic membrane is the least specific sign. So because the child has a red tympanic membrane, it is not meant that 100% he is having otitis media. For that, you need to have a tympanic membrane with bulging, which has got the immobility or the reduced mobility. And third one, there may be a air fluid level. And fourth, when you look with the otoscope light, the cone of light reflex is also lost. So cone of light is also lost, and you can not see the details of the tympanic membrane once the child is having acute otitis media. Now, as far as recurrent otitis media is concerned, 3 or more episodes of otitis media in 6 months or 4 or more episodes in a year is consistent with the definition of recurrent otitis media. Remember that nearly 1/3 to half of the children has a tendency to have a recurrent otitis media. And why the children are more prone to recurrent otitis media? Because their immune system is still developing. So they may not have the capacity to fight the infection that smartly and efficiently as compared to grown-up children. And secondly, the eustachian tube, the anatomy of the eustachian tube is quite different than the adults. And therefore, there is always a component of the eustachian tube dysfunction. And this eustachian tube dysfunction plays a key role in the development of all the middle ear diseases, including acute otitis media. So the eustachian tube is mainly required to balance the air pressure dynamics in the middle ear component or the middle ear compartment. And once this function is there, this air pressure dynamics are disturbed and the child gets recurrent infection in the middle ear. And this is what I want to highlight, that in children, the eustachian tube is straight. And as it is straight, the transfer of the organisms from the pharynx to the middle ear is very easy. As against that, in grown-up children or in the adult, the eustachian tube is not that straight. You can see the curvature. And as a result of this, the transport of the organism from the pharynx to the middle ear is not that easy. So this is why the children are more prone to recurrent infection. Now, whenever there is infection or allergy or both, there is an edema of the eustachian tube. And this edema causes intrinsic mechanical obstruction of the eustachian tube. So any factor which causes obstruction of the eustachian tube will predispose the child to a condition of otitis media. Similarly, there may be sometimes extrinsic mechanical obstruction of eustachian tube, like our enlarged adenoids, large tonsils, nasopharyngeal tumors, all can also give rise to recurrent otitis media. Sometimes there may not be either intrinsic or extrinsic obstruction to the eustachian tube, but sometimes there may be a functional obstruction of the eustachian tube because of the persistent tubal collapse in the children, because children lack the cartilage. There is a lack of cartilaginous support in the children. Most of the cartilage is not there. You know that cartilage is very elastic, and this elasticity is not there in the children, and therefore there is a functional obstruction of the eustachian tube as well. And last one, in cases there is impaired mucociliary clearance. When the child has got the recurrent viral upper respiratory infection, every time the upper respiratory infection is cured, but at the same time it causes some damage to the mucociliary to the cilia, and because of this, the damage to the internal cilia, there is a mucociliary clearance is hampered. So recurrent child infection, immotile ciliary syndrome, as well as the cartilaginous syndrome, these are the conditions which predispose the child to recurrent otitis media. Remember that, friends, that child with cleft palate, even Down syndrome, and child who has got the various craniofacial anomalies are having very high incidence of recurrent otitis media. Not only very high incidence, but they are often go for the complications of the otitis media as well. If you look at the risk factors for such recurrence, no, there is hardly important, most important that it is the bottle-fed baby. You know, the breastfeeding always protects the child from the recurrent respiratory infection, and otitis media is not an exception to it. When the child is bottle fed, because of the bottle fed, the bottle pushes the tongue back, and this elevates the tongue at the back, which in turn causes a blockage of the eustachian tube. So the bottle feeding is very, very hazardous as far as the otitis media is concerned. Similarly, if the onset is in the first few months of the life, if the child is attending to a day school care, if there is a bilateral otitis media, if the male gender is there, if there is history of otitis media in other siblings, and if the child has a recurrent respiratory infection, then these are the children are having a more chance of recurrence. Similarly, all these factors, there is overcrowding, poor hygiene, is common in lower social group, they are also more prone to recurrent otitis media. A genetic familial clustering has also been observed, and the genetic marker G2M23 is also associated with recurrent acute otitis media. So these are the factors. So if you want to prevent this otitis media, I think it is not only the antibiotic, but addressing these factors in its right perspective is also very, very important. As far as the cleft lip and cleft palate are concerned, or any craniofacial anomalies are concerned, these children are more prone to otitis media. The otitis media is present nearly in all the children under 2 years of age who has got unrepaired cleft lip and cleft palate. And once this surgical repair is carried out, this surgical repair is carried out of cleft palate is surgically repaired, then the chances of recurrence reduce to a great extent. Similarly, in a child with Down syndrome, there is poor active opening of the ET. So there is a tube dysfunction in a Down syndrome, and this results in the low resistance of the tube, and the child is more prone to recurrent otitis media. You can see this large, massive tonsil, which can again obstruct the eustachian tube, and this obstruction of the eustachian tube can predispose the child to a recurrent otitis media. As far as the diagnosis is concerned, it is a typical history. In the history, I have already mentioned that abrupt acute onset less than 48 hours of the signs and symptoms of middle ear infection or inflammation, and the signs and symptoms of middle ear effusion. Similarly, a thorough clinical examination, including ear, nose, and throat examination, head and neck examination is also important, because sometimes you might be dealing with a dysmorphic child, you might be dealing with a immunocompromised child. So a thorough systemic examination is important. You just cannot examine the ear and forget everything. So it is not a thorough clinical examination from head to heel is important. The otoscopy is the gold standard for the diagnosis of acute media. Gone are the days that you examine it with the torch and you say the child is in acute media. No, you have to have your own otoscope, and you should be very, very very practical by using about the otoscope. So you must know how to use the otoscope, and how to you have to find out whether dealing with a normal ear, a erythematous ear, or the ear who has got the otitis media. Sometimes a tympanograph is useful, which is a valuable tool to find out the presence of middle ear effusion. However, it is very important for the diagnosis of acute otitis media, and audiogram is always required for the hearing evaluation. So our certain diagnosis of acute otitis media involves all three criteria, that is rapid onset, signs of effusion, and signs of middle ear inflammation. So this is a normal otoscope. You can see the otoscope. This is the normal tympanic membrane, and you can see this erythematous bulging of the tympanic membrane because of the effusion. So as per the treatment of the acute otitis media is concerned, is a two important component. One is a symptomatic treatment, means the child must be comfortable. Child must be relieved of the pain, because the pain is intense. The pain is not allowing the child to sleep, and therefore it is very, very important that pain management is also important. And second component is the use of an antibiotic. As far as the symptomatic treatment of fever and otalgia is concerned, the drug of choice is paracetamol, and paracetamol is the mainstay of the management as far as the otalgia is concerned. It is very effective for all mild cases and in moderate cases. In some severe cases, sometimes a potent drug may be required. Then again, you can use ibuprofen or naproxen. Or very rarely, we use codeine. Of course, we do not use codeine routinely. We most of the time, in more than 90 or 95% cases, it is the paracetamol of drug, is a drug of choice which takes care both of the fever as well as the pain. If the paracetamol is not working, then we go for the ibuprofen. And most of the time, this ibuprofen should suffice. We usually do not need the use of the naproxen, or we do not use codeine as in our day-to-day practice. As far as the antibiotic is concerned, again, it will depend upon the age of the child, severity of the disease, whether the otitis media is unilateral or bilateral, and what is the immunization status, what is the immune status, whether the child is immunocompetent or immunocompromised, and all other factors and follow-up is possible or not. All these are required, and in that case, we will decide whether the child is required and requires antibiotic or not, and if at all antibiotic is required, which antibiotic is required. We'll discuss in the subsequent slides. In addition to this tool, there are other modalities are available, that is topical agents. They are additional, but relief benefit over acetaminophen in patient more than 5 years. So topical agents has some role, but they are not much helpful. So they do not have an extra edge over the use of acetamol or paracetamol for the treatment of pain and management. Home remedies, no control studies are available that can address the effectiveness and safety of, so we do not recommend it. And lastly, when we need to take the help of our ENT friends, that is myringotomy can be used for a children within extreme pain, as it provides almost immediately. So if the child has got very excruciating extreme pain and analgesic and antibiotic is not working, then as a emergency relief measure, a myringotomy can be done with the help of the ENT surgeon. So these are the three basic principles as far as the management of the otitis media is concerned. Now, whether to start the antibacterial, that is antibiotic or not, will depend. Most important among this is the age of the child, and whether disease is unilateral or bilateral, and whether disease is severe or non-severe. So, if the child is less than 6 months and the diagnosis of acute otitis media is certain, there is no doubt that you are going to start with antibacterial activity. But in some cases, you may not be that certain about diagnosis, but still you will go for the antibacterial therapy if the child is less than 6 months, especially when the disease is bilateral. Why? Because the chances of having intracranial complication like meningitis, mastocytitis, brain abscess are born in the younger age group. And these are the children often, they may not have completed all their vaccine doses. So as far as the vaccine-induced protection is concerned, also is little less in a younger age group. And because of this, even if the diagnosis is uncertain, if the child is less than 6 months, we always start the antibacterial therapy. Now, if the child is between 6 months to 2 years, then if the diagnosis is certain, we'll start the antibiotics. But if the diagnosis is not that certain and the disease is not that severe, and if the disease is unilateral, in that case, the observation policy is offered. The child should be kept under close observation. You may ask the child to bring twice in a day for the follow-up cases. And if the non-severe disease becomes severe, or if the child becomes more toxic, more febrile, you can start antibiotic. But if this follow-up is not possible, in that case also, you can start the antibiotic. And if the child is more than 2 years, then antibacterial therapy is required only in case of the severe illness. It is a mild otitis media is there. In that case, again, observation option can also be offered. Similarly, if the diagnosis is uncertain, in that case, if the child is more than 2 years, then observation policy is adopted. So observation is an appropriate option only when the follow-up can be ensured and the antibacterial agent can be started if the symptoms persist or the worsen. So child must be in a close follow-up. If that close follow-up is not possible, then you cannot provide an observation therapy. It is also very important, what do we mean by non-severe disease? So non-severe disease means there is a mild otalgia and fever is less than 39 degrees Celsius in past 24 hours. As against this, if the temperature which is more than 39 years and if the otalgia is moderate to severe, then we'll define that is a case of a severe otitis media. Now, once you have taken care that the child has got a certain diagnosis and the disease is severe, and you have planned to start the antimicrobial therapy, then the next question comes, what antibiotic would you prefer? So for that, you need to find out the microbiology or autopathogens as described by Dr. Pramod Jog, that what are the autopathogens? 70 to 75% of cases, it is going to bacterial. In nearly 15 to 18% of the cases, it can be, in nearly 25% of cases, it can be viral. In 8 to 10% of cases, it can be both viral plus bacterial. So out of this, the most common organism which is found is Streptococcus pneumoniae, then H. influenzae, Moraxella catarrhalis, and in some cases, group A Streptococcus. So out of this, the Streptococcus pneumoniae, H. influenzae, and Moraxella catarrhalis are the three important organisms as far as the pathogen or the bugs for the acute otitis media is concerned. If the child is infant has a high incidence gram-negative bacilli can take place, but it is more common in the infant below the age of 6 months. But usually, we do not consider them in the empirical antimicrobial therapy of the acute otitis media. So if you plan your antimicrobial therapy, you have to consider these three organisms, that is Streptococcus pneumoniae, H. influenzae, and Moraxella catarrhalis. Now, as far as the drug of choice is concerned, the first line is the amoxicillin, and there the dose is 40 milligram per kg per day and can be given for the period of 10 days. Remember, it is the amoxicillin, and amoxicillin. So you have to choose the possible narrowest spectrum of antibiotic, that is amoxicillin. As far as the pneumococcus is concerned, pneumococcus Streptococcus pneumoniae is concerned, all these non-meningeal strain which are responsible for causing otitis media, they have got very low MIC, and therefore this amoxicillin is still working at a lower dose of 40 milligram per kg per day. In the Western world, we use 80 milligram per kg per day, but it is not required for the Indian isolate. So it is very important that you stick to our routine 40 mg per kg per day. Now, if you have tried this amoxicillin and it is not working, in that case, you can go for the co-amoxicillin, or you have got the recent use of amoxicillin which has not worked, then you can give the co-amoxicillin. The idea of using this co-amoxicillin is that it is a beta-lactamase inhibitor, that is clavulanic acid. Now, out of this, all these organisms, this H. flu and Moraxella catarrhalis are the beta-lactamase producing organism. And to inhibit this beta-lactamase enzyme, you have to add the clavulanic acid. And therefore, if the first course of amoxicillin is not working, in that case, you can go for the co-amoxicillin. Number one. Similarly, the other option, instead of using this co-amoxicillin, still you want to stick to a narrow spectrum, you can give high dose of amoxicillin, that is 80 to 90 milligram per kg per day. And the purpose is that the pneumococcus, which has got the intermediate sensitive, which are not susceptible, and which are having a little higher MIC, this high dose amoxicillin is going to work in this case. And it is especially used in children where there is a recent antibiotic use, when the child is less than 2 years and the child is attending daycare center. In that case, even high dose of 80-90 can be used, and you can stick to a narrow spectrum amoxicillin. Any reason you may not be using amoxicillin, maybe the child has got the penicillin allergy, or this amoxicillin or amoxicillin is not working, then we have got the second line of drug, that is cefdinir and cefodoxime proxetil, or third one you can use even ceffuroxime. Now, out of this cefdinir, cefodoxime proxetil, and even ceffuroxime, no clinical trials are available which compare the efficacy and safety of each other. But out of this, the cefdinir is the most palatable one, and therefore the acceptance and compliance is good, and that is why the cefdinir has got a better response, therapeutic response compared to the other two drugs, and therefore the second line of drug will be a cefdinir. It also achieves comparatively a good concentration in the middle air fluid as well. So the second line drug will be a 14 milligram per kg. In some cases, child is extremely toxic, is vomiting, not taking orally. In that case, injection ceftriaxone intramuscularly 50 to 100 milligram per kg can be given one day. Even here it is mentioned a single dose may be enough. Sometimes the child may require for 1 to 3 days, and that is only reserved for the non-compliance or where the severe vomiting is there. Most of the time, literature says the antibiotic courses should be 10 days, but now the recent that a short course of 5 to 7 days for a children above the 2 years who are immunocompetent can be given, provided child should not have any chronic disease, child should not have recurrent otitis media, and child should not have perforation of tympanic membrane, and child should not have any craniofacial anomalies or any dysmorphism. In that case, even a 5 to 7 days course of antibiotic is enough if the child is more than 2 years. Now, once you have started this antibiotic, it is very, very important to follow the child. Then and then we can define what is the response, and then we can define that where if the symptoms have worsened or not, or the child is going for the complication or not. Now, in a case of a non-severe illness and failure of the initial observation, as rightly mentioned that we have started at 40 milligram, you can switch amoxicillin to 80 to 90 milligram per kg. If there is a severe illness and still there is failure of amoxicillin, you can give high dose amoxicillin clavulanic acid. A patient who fails even amoxicillin potassium clavinate, a 3-day course of ceftriaxone can be given. That is an injectable one. Children with vomiting or in other situations where oral administration is not possible, again a 3 days course of intramuscular ceftriaxone is enough. If there is a history of type 1 allergic reaction to penicillin, instead of giving amoxicillin or amoxiclav, you can give cefdinate, cefodoxime or cefuroxime, either of any one. This is a non-type 1 allergic because you know that there is a cross. If there is a type 1 reaction, in that case, even penicillin can have a cross sensitivity with the cephalosporin. And therefore, if the type 1 reaction is there, in that case, you cannot use even any beta-lactam. So you cannot use amoxicillin, you cannot use amoxicillin or amoxiclav, you cannot give cephalosporin. In that case, you have to give either azithromycin or clarithromycin. So azithromycin is a last choice. So because it is a 3 days course, compliance is good, once a day course, you should not ever use azithromycin. Say big no to azithromycin as far as otitis media is concerned. And in spite of this, if acute otitis media still persists after doing all this exercise, then a tympanocentesis is required, and this tympanocentesis is required. This tympanocentesis is required only for the purpose of bacteriological diagnosis. You drain the fluid out and send it for the culture and sensitivity and modify your therapy as per the culture and sensitivity report. Suppose if this tympanocentesis is not available, in that case, you can start the clindamycin. So the first line is the amoxicillin, amoxicillin, amoxicillin. If it is not working, you can give amoxiclav. If compliance is there, not there, vomiting is there, in that case you go even parenteral ceftriaxone. And last one, that is the cefdinate and ceftriaxone drug. And last one is the azithromycin followed by clindamycin only in area where the tympanocentesis is not available. So that is about the choice of the antibiotic. Now, as far as the this middle ear effusion is concerned, it is usually a part of the natural process of the otitis media. So all children who has got the acute otitis media, they will have middle ear effusion, and sometimes this middle ear effusion may persist for first 1 to 2 months. The persistence of this middle ear effusion or the fluid is not an indication for the antibiotic. So no additional antibiotic is required because the child has got the middle ear effusion. But if the middle ear effusion persists for more than 3 months, then hearing evaluation is a must. If the middle ear effusion is of a short duration, means persist for 1 month, 2 months, may not persist for 3 months. But if there is a doubt as far as the hearing loss is there, or if there is hearing evaluation is required, then in that case, even early intervention is required. So most of the time, the children will have the middle ear effusion, which will last for first 2 to 3 months. They do not require additional antibiotic courses, number 1. But any OME which persists for more than 3 months, a hearing evaluation is always required. In majority of cases, 70% of cases, this ME is resolved by the end of the first 2 weeks. In 20% of cases, it will resolve by the age of 2 months. And in 10% of cases, this middle ear effusion will resolve by the end of 3 months. So it is very, very important that this middle ear effusion does not work unnecessary use of the antibiotic courses. So, as I already said, that ME which persists more than 3 months or associated with hearing loss, then the audiometry is required. In cases where the ME persists for more than 3 months, or if there is an early hearing loss, in that case, antibiotic may be justified. There are debatable roles as far as steroids are concerned, but in 21% of cases, when the improvement was compared to antibiotic alone. So, steroid has not much role, but in some ENT surgeon may prefer to give the antibiotic courses with steroid. So, it's very, very important that so it is very important that they will, so in most of them, the antibiotic is required, only antibiotic, because antibiotic and steroids are usually not required, and steroids are not recommended by and large. Antihistaminics, decongestant has no role, and myringotomy and tympanostomy, tube insertion, plus minus adenectomy may be required. So some surgical intervention may be required in children who has got the recurrent otitis media. As far as the tympanostomy tube insertion is concerned, there are specific indications. If the medullary effusion is unresponsive to our antibiotic therapy and it persists for more than 3 months bilaterally, or if it persists for more than 6 months and the disease is unilateral, or at any point if there is hearing problem, then the tympanostomy tube insertion is indicated immediately. So what is more important is that in all the cases, it is not the symptoms of the child, but the otoscopic findings are very, very important. So a 10-day follow-up for 10-day follow-up otoscopy is a must. At that time, on the 10th day, when you examine the child, there will be fluid, but this fluid will be clear without any signs of inflammation over the tympanic membrane. On the other hand, if the fluid is there, but that fluid is turbid, and second, the signs of inflammation is there, in that case, you can warrant a second course of antibiotic. And third, these are the children where the middle effusion persists little longer, then hearing evaluation is required, right? And if there is a hearing problem anytime, then tympanostomy tube should be performed initially. Similarly, a recurrent middle effusion with excessive cumulative duration, when there is speech delay, when there is language delay, a child who has the recurrent otitis media, more than 3 attacks in 6 months, or more than 4 attacks in 12 months, when there is suppurative complication, when there is retraction of the tympanic membrane, these are the indications where tympanostomy tube insertion is required little earlier. As per otitis media is concerned, I think prevention is better than cure, but sometimes some chemoprophylaxis are required, that is amoxicillin, ampicillin courses during winter months. Usually they are less efficacy for the intermittent prophylaxis, and usually we do not practice it. Myringotomy and tube insertion decreases the frequency and severity of AOM, otorrhea and other complications, and may require prophylaxis if severe. And adenectomy reduces the recurrence by nearly 25 to 30%. Okay, so adenectomy has some role as far as the children who has got the adenoids plus recurrent otitis media is concerned. It is very important to note the complication. The complications are divided into 2 parts, intratemporal as well as intracranial. Out of this, most important, what Dr. Pramod sir has already said, that the hearing loss, speech problem, language problem, because these children, they cannot hear, they cannot speak well, they have a language problem. Not only that, they also have cognitive. So recurrent otitis media, deafness followed by recurrent otitis media, speech problem are one of the most important cause for the poor scholastic performance. So I think it is very, very important to prevent and treat this otitis media in time. So tympanic membrane perforation, chronic superior otitis media, retraction pockets, some children may develop cholesteatoma, sometimes mastocytitis, periostitis, labyrinthitis, adhesive otitis media, tympanosclerosis, ossicular discontinuity, facial paralysis, granulomas, and necrotizing otitis externa media. These are the local or intratemporal complications. But out of this, hearing loss, speech problem, language problem, and poor scholarly performance are very, very most important. In some cases where the child is maybe immunocompromised or sometimes some defect in the complement system is there, then otitis media can have complication, intracranial complications like meningitis, extradural abscess, cerebral empyema, focal and capillary brain abscess, sinus thrombosis, and even otitic hydrocephalus. So these can also occur in a children with immune competent, these children who are also immunocompetent, but these are less. They are in the textbook. We do not see that frequently, but what is more important is the speech problem, language problem, hearing problem, and poor scholastic knowledge is very important complication as per the recurrent otitis media is concerned. And the negative factors, the children who are exposed to passive smoking, young children at the onset of otitis media and middle diffusion, craniofacial malformation, Down syndrome, daycare attendance, and children who are not getting the breast milk in their early life, they have got the negative prognostic factors. And as far as prevention is concerned, the most important, very cost effective, I can say it is available without any cost, that is breastfeeding. The exclusive breastfeeding for the first 6 months is very important. Even if the child requires stop feeding, at least try to avoid the bottle feeding. Avoid bottle feeding supine position, that is bottle feeding. Similarly, you can eliminate or reduce the use of pacifier in the first 6 months of the life, second 6 months of life. Then you have to eliminate or the exposure to the passive smoking. So all the fumes and the air pollution is very control of the air pollution is very important. So during infancy and children, when the child is brought to a child care center, some arrangement at the school, this daycare center can be made where the large clustering of the children may not be there. There should be proper distance between the kids. So I think the overcrowding should be avoided. And there is one substance known as xylitol, which prevents. So this xylitol can be used, and most important, that is immunization. Immunization is very important as far as the. So we have got the various vaccines now. We have got the hip vaccine, we have got the pentavalent vaccine, we have got the pneumococcal vaccine, we have got the flu vaccine. So all these vaccines are very important as far as the prevention of the otitis media. We need to target organism, that is Streptococcus pneumoniae. For that, we have got the pneumococcal vaccine. You have got the H flu. For that, we have got the pentavalent vaccine, which contains hip. We do not have a vaccine for the Moraxella, but we have got the flu vaccine. So it will prevent the flu, because after flu, the incidence of otitis media is nearly 25 to 30% during flu season. So we can prevent the flu, and thereby we can prevent the acute otitis media. So that is all about the prevention. So remember, friend, prevention is better than cure. A single attack of otitis media can be detrimental to the hearing capacity of the child. So it is very important to prevent it and to treat it very methodically. So thank you, friends. If you have got any question, I will be very happy to answer it. Thank you so much.
So it was a wonderful session, sir.
Thank you.
It was, I think, now.
Thank you, Abhay.
Thank you so much, sir.
It was really a great presentation on otitis media, and you mentioned about the definition, you mentioned about the organisms, and I remember that viruses, particularly you mentioned about the flu virus, which also is responsible to some extent. These viruses, I must add, they act as the co-pathogens, isn't it? Many times, they set the stage for the bacteria. I always give the example of, if there is some family where the wife is waiting for the husband, and the husband is to be scolded, and the neighbor, who is like a virus, has already, said something about the husband in the ears of the wife, so that, already the neighbors, they will set a stage, so that these viruses, though they contribute to about, you said that 70% of the otitis media cases are bacterial, remaining, many of them are viral. So basically they act as co-pathogens. So I'm glad that you mentioned about the appearance of the tympanic membrane, and you told that the tympanic membrane, which is bulging, with reduced mobility, with air fluid level, and the loss of cone of the light. These are the 4 important parameters. And that's why everyone must have an otoscope in the clinic. And my teacher used to tell me that you must examine twice the number of eardrums as the number of patients, because obviously every child has 2 eardrums. So you must examine. And moreover, I always, use an otoscope and the ENT mirror, which our ENT colleagues use, because the children also, they love to come to me. They say, "वो तीसरी आंख वाला doctor है, उसके पास जाने का है." You know, they always say that I am a तीसरी आंख वाला doctor, because this visualization of the ear is also very, very easy. And then you also clarified that a child with otitis may or may not have fever. That is important. Okay. You also mentioned about recurrent otitis media and the importance of eustachian tube dysfunction, which is present in almost 75% of children with upper respiratory infection. So it is something one must remember. And the points which always, the promoters of breastfeeding always will speak, and they will always discourage the use of bottle feeding, which is very important. And the risk factors, which you so mentioned in details, particularly if it's a bilateral otitis media, a male sex, then the sibling with otitis media, recurrent respiratory infections, then the cleft lip and palate, a child with Down syndrome, and this overcrowding and the lower socioeconomic state. So whenever a pediatrician faces all these patients, they have to be very, very careful. And then in addition to otoscopy, you gave some other clinical indicators for diagnosis. And in the management, you have amply clarified that paracetamol plain can take care of fever as well as pain. So there is no need to think about other, analgesic in addition to paracetamol. So pain management and the antibiotic management. And in their antibiotic management, we all do understand that amoxicillin in the dose of 40 mg per kg is the first line therapy. And in the second line therapy, second line means when the child doesn't get relief from pain and fever in next 2 to 3 days, then one can go for amoxiclav. And I understand that high dose amoxicillin in the dose of 80 to 90 or ceftriaxone, they achieve concentrations in the middle ear which are useful to overcome the resistant pneumococci. And that's why that comes nearer to the second line therapy. And you also clarified that more than 2 years when a child is there, I remember to have read the American Academy, guidelines long back, where they had mentioned a word called deferred prescription. The prescription is deferred. So at the time when the parents come, at that time itself, you tell them that, see, wait for 3 days, give paracetamol, but after 3 days, so put a line on the prescription, and below that you have written amoxi or amoxiclav in whatever dosages you want. Okay. And we now know that azithromycin, though it's convenient as once daily and 3 days course and so on and so forth, it is a last choice because majority of these organisms are resistant to azithromycin. You also mentioned about otitis media with effusion and the tympanostomy tube insertion and complications, and particularly prevention by breastfeeding, avoidance of bottle feeding, and the vaccination, particularly pneumococcal conjugate vaccine. Now, some of our colleagues have asked a few questions, and one of them wants to know as to what is the microbiology of a child who comes to you for recurrent otitis media. Is it same as pneumococci and H. influenzae or moraxella, or there are some other organisms which are responsible for relapse?
So when there is a recurrent otitis media, which is acute, then again that organism remains the same. But if it's a chronic otitis media, then again the organism will maybe some pseudomonas or other organisms. So by and large, even if it's a recurrent acute otitis media, if it fits in the definition of acute otitis media, though it is recurrent, the organism are going to be same. But if it's a chronic one, persistent one, in that case, the organism is different. There, gram-negative plays an important role.
Okay. And one of the listeners wants to know what is the role of ear drops in a child coming for ear pain.
Ear drops is more of a psychological benefit. It did not help in relieving or healing the disease process, because whatever we are instilled, we are putting outside in front of the tympanic membrane. Actually, the disease takes place in the middle ear, which is behind the tympanic membrane. So our ear drops are not going to the area where the disease is taking place. It is not reaching to the site where the disease is taking place. So disease is in the middle ear, which is behind the tympanic membrane. So there is no point in adding anything where you have got the intact tympanic membrane there. Of course, if the tympanic membrane is perforated, in that case probably some local antibiotic might be working. But the inflammation and the cytokines are so huge that is local is not going to work. Only what is required is a perfect antibiotic concentration at the site of the middle fluid. That is required, and that is only achieved by systemic and not by the local.
Yeah, so our colleagues must remember, and that's why the title of today's talk is It is the scene of unseen. You cannot see the middle ear, and that's why giving ear drops has limited role. Particularly, I use it in otitis externa, where there is pain and all. And one important thing is that the pain in otitis media is so severe that in case if the eardrum is not visible, I'm sure Abhay, you will agree with me that one should not try to remove the wax to see the eardrum when the child is actively
so fragile, yeah.
It is very, very painful, and that's why many times it becomes a very difficult situation, because on one side the child has impacted wax, on other side he has otitis media, and then the drum is not seen, and many times we'll end up in giving antibiotics. So it becomes very difficult. Abhay, do you have any suggestion for this situation where there is plenty of wax, eardrum is not seen, and on one side their child is having fever, irritability? So what would be the best way out?
So if the child is very febrile, irritable, if the child is pulling ear persistently, or if the child, in that case probably I will not do otoscope that forcibly, but I will prescribe an antibiotic analgesic and ask after 48 hours. If the child is responding, my diagnosis is clinical. If the child is not responding, I will send it to the ENT surgeon.
Yeah. And that brings us to one question from our colleague as to what are the, situations where I need to refer to the ENT surgeon. So what do you think?
No, most of the time, acute otitis media should be our priority, number one. Second thing, all cases of otitis media does not require ENT reference. Only the children where some surgical intervention is required, or if they have tried 2 or 3 courses of otitis media, antibiotic courses, and the child is not required, I think the bacterial or microbial diagnosis is very important. In that case, you need to have a fluid to be drained. So where I need the help of the ENT surgeon. Similarly, when there is a hearing loss, evaluation of hearing, or if there is a child who has got the otitis media where the hearing loss there, and child is already having a scholastic performance, poor scholastic performance, a sibling, I think in that case, I will not take any chance. I will straight ask to take the help of the ENT surgeon and get the proper evaluation done. So there is a definite role, but all otitis media is not equal to ENT reference. I will take at myself in nearly 50 to 60% of cases. In nearly 20 to 30% of cases, I will send because the parents want it, and nearly all 10 or 20% really I want because they are recurrent and require some intervention.
Yeah, I agree. And I must add that with due regards to all the ENT surgeons about the antibiotics and the organisms and all, we keep reading a lot, and we are, more, I may not say knowledgeable, but we really know, lot many things about the organisms. And
they usually end up giving 2 or 3 antibiotic courses in 20 days. Usually it's not required. 10 days course and only observation is required for the next 10 days. But they usually give 2 or 3 antibiotic courses for the subsequent 3 weeks because the child is having fluid inside. It is not required.
Yeah, maybe at the most I can add to that many times, children with allergic rhinitis have otitis media as a comorbidity, just as they have sinusitis or adenoiditis. So maybe at that time we might have to have the opinion of an ENT surgeon for evaluation of the upper respiratory tract. So at that time, and of course, all those situations like, this tympanostomy tube insertion and others, you can always have the help of your ENT surgeons. Remember, I call pediatricians as ENT physicians, and other ones are ENT surgeons. So let the surgeons do the surgical job, and let us continue with our job of being physicians. Anyway, with that, Abhay, I think most of the questions have been answered, and I must thank the audience for having these interactive questions. I also thank Abhay